always a debate whether Fabry disease is an adult onset disorder or it's a pediatric onset disorder. So we have diverse views. So I use some medications for this disorder as well. But I have no financial relationships with any company who are giving us drugs for this, some charitable access, some as drug trials, and there is no conflict of interest. So this is one disorder which is very interesting. We know that a gene produces a protein, and the protein can be enzymes, hormones, structural proteins. So when it is an enzyme, and if it is deficient, an enzyme is a catalyst, and when there is a deficiency of the enzyme, there is either accumulation or deficiency of the product. So here in most of them there is accumulation, and they all together form the storage disorders or lysosomal storage disorders. Enzyme is required in very small amounts. So most of these disorders are either autosomal recessive or X-linked. So say Fabry disease is what is the inheritance pattern we have discussed. Fabry disease is the inheritance pattern. It's a X-linked disorder. So we just leave it like X-linked, not recessive or dominant, because it is the males who manifest, but females also have some manifestations. So we know lysozymes are the garbage bins, and they metabolite, they have some enzymes which will help in metabolism of very large proteins or glycoproteins or large molecules, and if they are defective, there will be accumulation. So these are the various disorders we group according to the what material is getting manipulated or accumulated, like mucopolysaccharidosis, sphingolipidosis. So these are the common disorders where we see. So Fabry disease is one of the sphingolipidosis, just like Gaucher. So Gaucher is the common of this lysosomal storage disorder. But it is very interesting to know that when we talk of MPS, that is mucopolysaccharidosis, there will be contractures, there will be hepatosplenomegaly. We talk of Gaucher, there is hepatosplenomegaly, very large because they are MPS 1, there is corneal clouding because they get deposited in the various organs. Then this must be MPS 4, you know, Morchio. MPS 4, the bones, this is called dysostosis. But Fabry disease is something which presents with, this is actually acroparesthesia. Previously I used to put one picture of burning fingers. So they have some burning sensation, and people will pass it off as neurosis, some psychosis, never know. And the average diagnosis time from manifestation to diagnosis is around 9 to 10 years, all over the world, just because the symptoms are so non-specific. So Fabry disease is an unrecognized multi-system disorder, and the nephrologists come in play when the kidneys get affected. No obvious mental or physical handicap. See, there is no hepatosplenomegaly thing, but there is decreased life expectancy without treatment. So this is one child or a near adult who came around 19-20 years with history of pedal edema for last 6 to 7 years with some GI symptoms, and because of edema he kept on going to the nephrologist and to the liver experts as well. So there was microalbuminuria, creatinine was fairly normal to start with. Now even after enzyme replacement we could not salvage his kidneys. And renal biopsy at that time, so the pathologist was the brilliant person in our group who told that there are features of Fabry disease. These vacuolations are probably very, very specific of Fabry disease. And we did enzyme assay. So we did eye examination. Fabry disease has very typical eye presentations. And acroparesthesia was very doubtful in them, but he presented with renal variant, right? So in a systemic review and meta-analysis has shown that Fabry disease, though common, but if you see a large chunk of people with renal transplant who are going to renal transplant, there is very small amount of people who have actually Fabry disease, but we need to screen them because there is no other way to find that whether that person has Fabry disease, and it has got a important therapy. So although overall prevalence of Fabry disease is low in patients with overall kidney involvement, in order to provide timely and effective treatment, we need to screen them. And immune function in males with Fabry disease is similar to that of other individuals. So there is no contraindication of transplant in people with Fabry disease. And as we have already discussed, the transplantation of kidneys from female heterozygous, that means female carriers, should be avoided because they have manifestation, even females have manifestation. So Fabry disease classically has been classified into three variants. One is the classic variant, which is actually a childhood or adolescent onset, the renal variant and the cardiac variant. And you see, the enzyme level is different. The classic variant, the enzyme level is less than 1% of the predicted, and for the renal and cardiac variant, which are late onset variants, the enzyme level is more than 1% of the activity. So how do they present? So the age of onset for a classical is around 4 to 8 years. For renal variant it is more than 25 years or something around 25 years. For cardiac variant it is something around 40 years. Average age of death without treatment is around 40 years for classical, around 60 years for renal, and even more for cardiac variants. Angiokeratoma is a very specific skin finding which is very classically found in the classic variant, sometimes also in the renal variant. Acroparesthesias are somewhat present in renal, but it is acroparesthesia with burning sensation, abnormal sensation, hypohidrosis or anhidrosis. These are very classical of the classic variants or the childhood onset variant. Then corneal and lenticular opacities. In heart there will be cardiomyopathy or left ventricular hypertrophy, and stroke is very common in the cardiac variant. They might just present with a stroke. Young onset stroke we always think of Fabry disease, and kidney is affected in both the classic and the renal variant, and this is how we classify them overall. So the other involvement, this is a paper from our group. See how the angiokeratomas look like. So they are brothers, not brothers, but different people with Fabry disease. They can present with stroke. So renal type is fairly common. Then renal failure, some of them present with renal failure, neuropathic pain in this group of people we have screened along with mutation with Fabry disease. How we do is an enzyme assay. So it is a fluorimetric assay. So it can also be done with a Hill prick, right? So screening can be done with Hill prick. The specific enzyme activity is seen by a fluorimetric method, and you see that there is always a control enzyme, and enzyme assay is expressed as micromole per minute per milligram. Per minute means the activity, and per milligram is the substrate which is being degraded if the enzyme is present. And molecular testing is, we do it by Sanger sequencing because we have been doing it for very long. First as a project, now we do it in clinical basis. In Sanger sequencing, there are 7 exons. We design primers in the intron exon boundary. Then we amplify each exon and part of intron we have discussed, that is 20 nucleotides proximal and distal to each exon. And then each exon we will do a sequencing from the forward and also with the reverse to find whether there is a mutation. So we cannot see this sequence and tell that there is a mutation. So we have to compare it with a sequence, with a reference sequence. So this is a Sanger machine, how it looks like. This is a PCR machine, and this is how the chromatograms look like. For Fabry disease, it is an X-linked disorder, so there is only one X chromosome. So if you do in the males, you don't get heterozygous peaks. You have to match it with the reference sequence. So that technique is called a BLAST, that is basic alignment search tool. So these are all free of cost available. So we do a BLAST and find out. So you see that mothers are carrier mother. So the picture is not well. And there is some genotype-phenotype correlation. There are some variants which are being found in newborn screening in Taiwan, which causes late onset. Probably they can cause late onset cardiac disease, but still because therapy is available, people will start doing newborn screening. If you see all adults of lysosomal storage disorders, Fabry disease is the second most common. The commonest is Kausik disease. And again, this is one group who have done LSDs in adults, and you can see that Fabry disease is one of the commonest in adults. So prevalence of Fabry disease is fairly high. I will tell about prevalence later on as well. So they are present in patients on dialysis, patients with hypertrophic cardiomyopathy, and they can also be picked up by newborn screening. In newborn screening in northern Italy has found incidence of 1 in 7,000, and all of them had the later onset Fabry disease. Then enzyme based, we have already told that in Taiwan they have done, and there are very common or a very specific mutation in their community which gives rise to a late onset Fabry disease. In Indian data, this is the Indian data, I do not know why it is not coming very well. So anyway, all of them are males, but females do also manifest, and you see the age of onset, 5 to 10 years, 10 to 20 years. 10 to 20 years is the maximum number, so we can jolly well tell that if we are prudent enough, we can pick them up early, and most of them are classical Fabry disease. And the age of diagnosis is again between 10 to 20 years. So this is the first Fabry child which I had seen while I was doing my super specialty DM, and the boy was in around 13 years. He came with complaints of burning pain in fingers and toes and fever off and on for last 6 years. So as I have told you that it is average 9 years for diagnosis. So there is no history suggestive of an infective foci, but he started thinking that he has fever. His parents also started thinking he has fever. There is normal sweating, no family history of similar problem. And our rheumatologist thought that he does not have a rheumatological problem and probably he has a neurosis, and he kept on coming. So hemogram was normal because we always think of sickle cell anemia in our country, renal function, sickling test, echocardiography, but we had something in mind, so we did a eye examination, and we found that there are corneal opacities, and the clinical clue was neurogenic pain, rise in temperature, mild coarsening of face. I don't think he really has, and it's a male. So we did an enzyme assay. So this is the enzyme for Fabry disease, and it was really low, and we thought that he has Fabry disease. Later on we did a mutation. At that time I have told you, so this is a nonsense mutation. So variants can also be expressed as single letters. So this was the mutation. Mother also had cornealopathy, some proteinuria. Younger brother also had got gastrointestinal symptoms, and later on we found that younger brother also had got Fabry disease. So in that case, mother must be a carrier, and she also is manifesting. And prenatal diagnosis is available for them, but the best thing is to do a molecular, and this is the first we have put in Fabry disease from India. This is the first child we had reported. The treatment is for neuralgia. They suffer from neuralgia, and we can use carbamazepine, sometimes phenytoin or gabapentin for neuralgia, and probably renal transplant and hemodialysis, then some cardiac and pulmonary support. For angiokeratomas, which I have shown, which are in the buttocks or in the periumbilical region, we can use laser systems for cosmetic purpose. There is enzyme replacement therapy available. So these are the two brand names by the two companies who produce these drugs, and it is given through intravenous route every 2 weeks. And you see that we use a mesh in the tube because they are protein products. They are available as dry powder or sometimes as liquid. They infuse periodically, that is means every 2 weeks with specific dose, specific protocol, and generally required lifelong. So we actually started that child with enzyme replacement therapy, and we can see that average painful episodes have decreased 6 months after ART. Average frequency of unbearable pain, frequency of using carbamazepine has also decreased, and number of school missed were also decreased. So it works, enzyme replacement works. So these are the two brothers after many years. So which we have started enzyme replacement therapy, and both of them have good kidneys, normal renal function. These are another two brothers. The one I shown that in aquaparesthesia how it looks like. So all of them are on enzyme replacement therapy, but the later two brothers have stopped enzyme replacement because many of them cannot understand that it will salvage the kidneys. So even if you get it free of cost, this is a disorder, and somewhat people with Fabry disease have, most of people with Fabry disease have some psychiatric problems. They have psychiatric manifestations as well, depressions and all. So it is not only drugs which can help them, and these two brothers has actually recently stopped getting medications. The other two are continuing, and he, after 10 years or 12 years of ERT, he has grown tall, well, and this is the pedigree of them. You see that these two brothers, they are now 34 and 30 years. So he has got two kids now. The 30 years brothers have also got married. He has got one kid. The sister is actually a carrier, right? But she, and this 6 years son of the sister has started getting aquaparesthesia. But this is the adolescent and adult onset disorder, a non-lethal disorder. To tell them about prenatal diagnosis, I do not know how it is ethically correct or not, and the therapy is well available. The lifespan is up to 40, 60, 80 years for many of them if drug is given. So it is not correct. We do prenatal testing for many disorders. This is how we do take out amniotic fluid or coronary sample. We do it ourselves with our own ultrasound machines. But I have never done a prenatal testing for a Fabry disease. And even after counseling, we offered that we had a drug trial. We offered the sister's son to get into that trial, but they did not apply now. So, well, what happened to the anyway? I saw from my but I had. So then our old, this is our old group. This is our new group. From old group, there are various people who have helped me learn. This is the new group. This is our campus. This is my family, my wife, my two children, and this is my extended family who rides motorcycle with me. So thank you so much.
So, Kausik,